Good afternoon, ladies and gentlemen. My name is Pierre-François Laterre. I'm head of the ICU at the St. Luke University Hospital. And my goal this afternoon is to present you the data of a phase 2 clinical trial in septic shock. And so how adrecizumab in patients with elevated adrenomedullin levels do respond to this intervention. These are my conflicts of interest. And just to remind you that one of the key characteristics of septic shock is that it is associated with an alteration in the endothelial function, with an increased permeability and a disruption of the tight junction. And so what is known is that adrenomedullin is playing an important role in the regulation of endothelial function. It has been shown that if adrenomedullin concentrated in the interstitium, it is inducing vasodilation. On the other hand, elevated adrenomedullin, or in the absence even of elevation, but adrenomedullin is protecting or at least improving the endothelial function and reducing vascular permeability. It has been shown that patients with severity and severe septic shock have an elevated ADM, and that the cutoff value of 70 mics is able to be correlated and predict outcome in these patients. So therefore, what has been built is an antibody towards adrenomedullin, so adrecizumab, and this antibody is binding adrenomedullin, and in fact, because of this molecular weight, stays in the circulation and do link and bind adrenomedullin from the interstitium, and so therefore elevates the concentration of bioactive ADM into the circulation. So expected to reduce vasodilation on the one hand and improve vascular integrity on the other hand. This has been tested in preclinical models, and the goal here is to show you that after a phase 1 study in healthy volunteers showing safety, it has been tested in patients with septic shock in a phase 2 trial. This is the design of the study. So patients had to have septic shock defined by the sepsis-free definition. They had to be treated within 12 hours of shock, have an elevated bio-ADM, so above 70 picograms per ml, and be approved by the CCC. There were 3 arms: placebo, 2 milligrams per kilo, 4 milligrams per kilo, and they were followed for 2 weeks, 1 month, and up to 3 months. And so at the end of the study, more than 450 patients had been screened. More than 150 were not eligible, either because they had a low bio-ADM, so below 70 picograms per ml, or they had other inclusion-exclusion criteria. So we were left with 301 patients randomized in the 3 groups, 152 for placebo, and 2 groups of 72 and 77 patients, either receiving 2 milligrams per kilo or 4 milligrams per kilogram. And so these are the baseline characteristics of the population. As you see here, they were well balanced in terms of age, severity based on hypertension, based on the respiratory rate. There was a slight difference of 1 point in the body mass index, but except this, there was no difference. And the focus of infection was also well balanced in between intra-abdominal, lungs, and other infection. So the first objective of the study was safety. And as you see here, if you compare the placebo with the 2 arms of 2 milligrams or 4 milligrams, there was no difference in the incidence of adverse event. If you look at the incidence of adverse event leading to death, there was also no significant difference, even a lower incidence in the high dose treated group. And therefore, the first objective was met, meaning that there was no significant difference of treatment emergent adverse event in between the 3 arms. Now, looking at another endpoint, meaning the duration of organ dysfunction and the severity, we've been using here a sepsis, a serious sepsis index, so sepsis, je fais une pause. So we've been using a sepsis support index. And as you see here, even though this score is less commonly used, there's a trend in favor of the treated arm with a lower sepsis support index when receiving either the 2 milligrams or 4 milligram dose. If you look on the right part of the panel at the change in the SOFA from baseline, you also see that in the two treated arms, there was a reduction of 1 point in the SOFA score over the course of the follow-up of the first week compared to the placebo arm. Now, looking at a secondary endpoint, this was part of the study, and so the proportion of patients surviving, you see that in the intention to treat population, the survival curve tended to be improved in the treated arm compared to placebo, even though this did not reach significance. But at least interestingly, the two curves separate quite early and never cross. If now we compare placebo with 2 milligrams and 4 milligrams, the same applies. Once again, not reaching statistical significance, but at least at no time crossing the curve of the placebo arm. Now, in addition to this analysis, we also looked at the same population, but looking at a group of patients with a low DPP3, and I'll come back to the interest of DPP3. And when we excluded patients with elevated DPP3, we were still left with 264 patients. And this is the distribution in between the placebo, the 2 milligrams and 4 milligrams. Why DPP3? Because DPP3, so therefore it's a dipeptyl peptidase 3, and it leaks out from the cells that are dying or necrotizing, and this DPP3 is playing a role on degrading the angiotensin II, but also enkephalin, and associated with worsening organ dysfunction, seems to play a role in cardiac depression, but also because of the degradation of enkephalin in kidney dysfunction. So we excluded in subgroup analysis the group of patients with very elevated DPP3, but this was a small number of patients. And when we looked at the outcome, the same curves were found. So an apparent survival benefit in the adrecizumab treated arm compared to placebo. This is for the intention to treat analysis. But when we looked at the population with a level of DPP3 below 70, the difference was bigger in terms of survival benefits in the treated arm, once again, not reaching statistical significance, yet confirming the curve observed in the ITT population. Now, if we looked at the 2-week survival and the 1 more survival, same applies. You see the relative risk reduction in mortality in the treated arm compared to the placebo, short-term, mid-term. So therefore, this goes in the same direction as the initial analysis of the ITT population, and further supports the potential benefit, even though, once again, this is a phase 2 trial and not power for a difference in mortality. Now, looking at organ dysfunction, using this time the SOFA score, you see that the change in the SOFA score from time 0, so inclusion, to the following days, there's an improvement in the organ dysfunction in the treated arms, and this goes in lines with the observed results in terms of mortality. This is the same data, but in curves here, the change in the SOFA score in the placebo arm and in the treated arm. And if we enrich this by excluding a patient with elevated DPP3, this becomes significant. This is, of course, a post-hoc analysis, but reinforcing the fact that it seems that there is a signal. Now, this is the data of pharmacokinetics. Not surprisingly, higher dose is associated with a different area under the curve, but this is confirming also somewhere the expected half-life. You see that the terminal half-life was 7 to 8 days. And so here somewhere the additional benefit of this study, because this is one of the first study in septic shock guided by the use of a biomarker, is that using bioADM to select the population to be treated with a drug, and in this case, an antibody directed against adrenomedullin, and if you're adding DPP3, you will enrich the prediction to therapy. If we had no biomarkers, you had no enrichment. Using one biomarker may simply detect and be used as a prognostic enrichment. Now, here, the combination of both seems also to predict the likelihood to respond to a therapy. So this will, of course, need to be further addressed in a phase 3 trial, but at least the signal here is interesting. So to conclude, Adrecizumab given on top of the standard care was well tolerated and showed a favorable safety profile without any safety concern. In terms of efficacy, so these were a secondary endpoint, it seems that this antibody has a positive trend on short-term mortality. Also demonstrates a improvement in organ dysfunction. So therefore, a further study should also address the combination of detecting patient with septic shock, but adding biomarkers, so bioADM together with TPP3 to select the population to be treated with this drug. And so this needs to be addressed in a following study. But the beauty of this phase 2 trial is that a biomarker guided the selection of the population, and the use of biomarkers seemed to be associated with a therapy signal. Thank you for your attention.